welcome to today's Bringing the Future Forward webinar. I'm your host, Bobby Patrick with the Medical Alley Association, and today we have a great panel here to talk about hospital at home and the future of care delivery. Our title is You'll See the Doctor Now, Hospital at Home. You know, the concept of hospital at home is not new, and there have been programs in place for over 2 decades, but the pandemic brought a renewed focus and interest on its use. And the partnership between Mayo Clinic, Kaiser Permanente, and Medically Home exemplifies this. While this significant partnership will make up a large part of today's discussion, we'll also look to peek behind the curtain and hear our panelists' insights on how the concept has evolved, what challenges remain, and how innovation will continue to drive benefits for the patients in the delivery of care in their homes. And so with that, I'll have each of our panelists introduce themselves, and then we'll get into the discussion. So up first is Raphael.
Hi, everyone. Raphael Rakowski. I'm the executive chairman of Medically Home and one of its founders.
Great. Stephen?
Hi, everybody. Steve Brody, an infectious disease doc with Kaiser Permanente and an executive vice president for the Permanente Federation.
Excellent. And AJ?
Hi, everyone. I'm AJ Dunn. I serve as the chair of Advanced Care at Home and Digital Practice Strategy within Mayo Clinic Center for Digital Health.
Awesome. All right, so let's get right into this. So Raphael, I'm going to start with you, and I'm really excited to hear from you today on this topic overall. But first, can you talk to us a little bit how hospital in the home works? You know, everyone's familiar with a telehealth visit now, but hospital in the home is clearly something very different. So can you walk us through what the patient sees and how it's executed by the provider, and then maybe touch on, you know, how is Medically Home's approach different?
Yeah, so maybe a minute of background, Bobby, would be helpful. So the hospital at home idea has been around almost 3 decades. A lot of it really incubated in Australia and Western Europe, but the model up to now has been focused on patients that were hospitalized, but typically lower acuity and could be handled safely and effectively with a physician house call for a few days and some scheduled nursing visits. As you move up the acuity scale of a patient and their stability changes and their need for rapid response changes, you need a completely different model. So about 12 years ago, we incubated this idea of higher acuity, complex care in the patient's home, which was different than the traditional physician house call and scheduled nursing visits. So I'm going to walk you through our model, which is the higher acuity model. So typically what happens is the patient's admitted into the program a number of different ways, either directly from the emergency department where they're given an option either to be admitted upstairs in a med-surg bed or be taken home. Another way is post-surgery. Again, same option, be cared for in the hospital after surgical care. Another way is the patient's actually admitted from their home to their home with an emergency department visit that's brought to them to their home. And there's a host of other ways, including patients who've enrolled in clinical trials, and we take care of them during the entire course of a clinical trial. So they enter one of those ways. They're now home. It takes us about 40 minutes or so to set up their home with technology that includes vitals monitoring, 2-way audio video communication, backup power, backup cell signal, and a kit that includes durable medical equipment and supplies. All of that is set up by a paramedic in about 40 minutes. That patient is now set up, and the way that the clinical care works is think of 2 different cohorts of clinicians that are caring for them. One is those that are the attending physicians and nurses. They're sitting in a command center centrally. And in the case of Kaiser Permanente, that's in California. And in the case of Mayo Clinic, that's at AJ's operation in Florida. Those clinicians operate around the clock and care for patients and interact with both patients and families 24/7. So that's the clinical care, call that the function that's attending the patient and their care. And they round the patient very similarly to the way they're rounded on in a hospital. Then there's all the clinical care that comes to the patient at bedside. That's brought to the patient from medical orders that are written in that command center. So everything from nurses, paramedics, infusion nursing, phlebotomists, PT, OT, imaging, labs, all brought to the patient on medical orders that are generated inside of the command center. So you have the technology in the home, you have the care that's centrally delivered and managed in the command center, and then you have the distributed care that's coming to bedside. All of that is managed by software that interacts with the host electronic medical record. So the 4 pillars of the model are the command center, the technology in the home, the capability to bring care to bedside, and the software that integrates this all into a virtual hospital model. That's the model in a nutshell. And the difference to your question, Bobby, is in a lower acuity model, you can safely schedule physician visits for 3 to 4 days to the home, schedule some home infusion or nursing visits, and the patient will be fine for a lower acuity diagnosis, let's say like a cellulitis. But as you move up the acuity scale, these patients require rapid response and different capabilities. So that's the difference between the two models.
Very interesting. And so Steve and AJ, I'm interested in any thoughts that you have to build on that. But let me sort of pose the question maybe a little different to you two. Kaiser and Mayo are two of the most forward-thinking healthcare providers in the country. And I want to get a little bit better understanding of why you're entering into this partnership now. And to put a fine point on it, how will patients benefit differently than they would if you had just separately gone about this rather than sort of all together? And so AJ, maybe we'll start with you and then I'll go to Steve.
Sure. Well, thanks so much, Bobby. For Mayo Clinic, we had our leaders in early 2019 go through a planning exercise looking at the year 2030 to envision what the healthcare landscape would look like in the year 2030 and what we would need to do to best meet the needs of our patients. And what we quickly realized is we needed to significantly accelerate digital transformation. And so we started to invest in platform business solutions and operating solutions and the build out of an internal center for digital health. And we quickly identified home hospitalization as an area in which we wanted to bring some capabilities to the table. And so we went through the standard build, buy, or partner analysis. And as we looked at the landscape, we realized that we could internally build the solutions if we wanted to do a low acuity model. But as Raphael mentioned, if we wanted to do a high acuity model, we really needed to accelerate through a partner. And we either could buy something as an off-the-shelf solution or invest in a strategic alliance. And the reason that we decided a strategic alliance and partnership with Kaiser Permanente is we looked at this space and what it would take to truly unlock this space. And that was real significant advocacy in terms of shifting the regulatory environment, shifting the payer environment, advancing technology. And as we saw the opportunity to be able to move this forward in a way that would best meet the needs of our patients, we decided not only to offer this as something that we would do for our patients, but we also wanted to enable the broader market so that patients across the country would have the benefit of really high quality home hospitalization capabilities as one part of a broader full spectrum of care. And Kaiser was just the perfect partner in terms of Kaiser, Medically Home, and ourselves being exceptionally patient-centered to make sure that we do this with the right motives.
Yeah, and let me tag on to what AJ is saying here. So, for Kaiser Permanente, I mean, this has been part and parcel to our strategy when it comes to hospitals. So when I think about our journey over the past decade, increasingly we've been able to institute techniques, improve quality, improve safety approaches. And so patients are, just by definition, moving quicker through the hospitals. And in some cases, particularly surgery, surgical procedures that used to be done in the hospital are now done outpatient. And the next natural extension for us back in 2018 and 19 was to begin to explore what does that look like for a medical patient. And of course, this requires technology, it requires scale. And so those two things really have come of age. And, when we first met with Medically Home, to look at the ability of, not only just looking at the technology that Raphael was explaining that goes into the home, but it's all the back end work, all the vendor contracts, all the redundancies to make sure that you're moving at the speed of care. And in an acuity setting like what we're talking about, you can't measure it like a home health visit where it happens in 24 hours or 48 hours. This has to happen in the speed of minutes to hours so that you get the right care into the home. So I think that was part of the reason Kaiser Permanente became very interested in working with Medically Home. And then the Mayo partnership, I think, unlocks the ability to scale on a larger clinical level. I mean, we're coming at this from, very interesting and varied backgrounds in terms of parts of the country that we're in, to begin to think about how do you clinically scale this with remote monitoring, remote settings. How do we combine our clinical expertise together in a way that hasn't been done before, actually, quite frankly, in this country. And I think we have a lot to be able to share with each other and then with others. And then I can't emphasize enough, the other part to think about here is we have an opportunity to think about how we structure what the models look like in terms of what are the prospective payment models look like for hospital at home. And we're really starting with a brand new model of care. And so I think we would love to be able to contribute together to come up with what that viable solution for the country looks like going forward in the next decade or two.
Yeah, that's great. Raphael,
Bobby, just to tack on, I'm
Yeah.
sorry, I apologize, I was on
Yep.
mute. This is one of those things, it's such an interesting phenomenon that people have often asked me, like, when is the market for hospital at home going to arrive? And I always answer the same way. If you decide to do the hospital at home application for your patients, the market has arrived. You can't wait for something to happen. It's you that's actually making it happen. And the real power of the combination of Mayo Clinic and Kaiser Permanente in the marketplace has resulted in an extraordinary level of amplified interest in the model because Mayo and Kaiser have decided to do and lead it. And I can't overemphasize the difference in activity before and after the announcement.
Yeah, I'm certain that's the case. And sort of some of the things that you, AJ, and Steve touched on, I want to come back around to. And part of that is just that, so taking a step back, and Raphael, this sort of came out of a conversation that we had prior to the webinar here, is just looking at the state of healthcare delivery overall and how the COVID-19 pandemic has led to the unlocking of care delivery. And maybe you can talk a little bit about that. And I'd like to hear from all three of you on this one, but we'll start with Raphael. You know, in particular, how assets are being reconfigured to align more with patients, not just in hospital home, but really beyond that as well.
Yeah, and I first, I appreciate the question, and this has been one of the most interesting journeys for me. The last roughly 9 months, I've spent most of my time in rural Oklahoma, of all places, exploring how this medically home idea, decentralization of care delivery, applies to not only a rural dispersed population setting, but to a very overly dominant Medicaid population who are underserved for multiple reasons, not the least of which is social issues. So what it takes you to quickly is you don't have specialists in a typical rural community. So oncology would be a great example. So to get any kind of oncology care, you have to get in the car, if you have a car, and drive 150 to 300 miles to a cancer center somewhere in your state. So lack of specialty care, lack of 24/7 access to primary care or emergency care. The hospitals are typically community access or critical access hospitals that are basically underserved in multiple levels because they don't have enough volume to draw the type of providers that are needed to sustain a high quality clinical operation. So as you look at these communities, and you realize the medically home model is not a hospital at home model. It's a care delivery transformation model, because once you have the command center operating 24/7 with hospitalists, with ED docs, you can just as easily add specialists, and you can tether those specialists, those ED docs, and those hospitalists to local community provider resources, from internists to community health workers, to NPs, to other APPs. So what we're discovering in our work there is we can transform the whole delivery of care. As you look at the pressures on care delivery in a rural setting, you're forced to recognize there are ways to deal with this. And the example I love to use, Bobby, is imagine if tomorrow, for whatever reason, all the buildings that currently deliver healthcare, whether they're hospitals, skilled nursing facilities, or clinics, they went away for a big hurricane. What would we do? And the answer is we'd centralize our clinicians where the thinking takes place. We decentralize care for patients at the point of care, and we would use technology to weave it all together. And we would do a lot of peer-to-peer work where the best minds could actually democratize care access for everyone. That's what we would do if we were forced to work without facilities. And all we're doing really is, because urban settings really rural settings force that thinking, we're actually applying that thinking now. And I think what that'll lead to, frankly, given the current mood around health equity and disparities, it's going to force a new conversation of what healthcare delivery looks like if we can democratize that access for everyone. And that's what at least I've been learning, because we're in this rural setting.
That's it. That's very interesting. And I'm going to want to come back to health equity as part of this in a little bit, but I'm interested in Stephen and AJ. So Steve, maybe we'll start with you and then go to AJ on the same question.
Yeah, so Bobby, the hurricane happened actually. So it was the COVID-19 pandemic, if you will. So when I think about it, and I'm looking at from the full spectrum of care, right? Because we at Kaiser Permanente have responsibility for both the outpatient and inpatient side. And so, a lot of the care that was driven early on in the pandemic had to be driven by definition to outside of the four walls of our buildings, either because of capacity issues, or safety issues, et cetera. And so, this transformation of telehealth, for the entire spectrum of care occurred like literally overnight. And of course, I think we're still going through a transition here where we're determining, what can still be done via telehealth, what can be done or needs to be done in person. But even if it has to be done in person, does it have to be done in the four walls of a medical office building or in a hospital? And I think what we were able to prove to ourselves, and I really mean this to the royal ourselves, meaning our patients as well as clinicians, because you got to get clinician buy-in here too, that this is safe, it's viable, that it's going to be responsive. If I write an order, that it's going to be fulfilled in a timely fashion. We were able to sort of prove those things can occur at scale. Whether it was low or high acuity. And the beauty of what this program does is if you focus on high acuity, these other venues of care, when we talk about skilled care, I'm really talking about like skilled nursing care. When I'm talking about, emergency at home care, those things become possible if you're able to handle a high acuity type patient. And I've often used this example. If we have a patient that we are able to admit to the home for a classic condition that would require medical, surgical, hospital ward care in a hospital, and they need skilled care, there's no way I'm going to discharge that person from their home into a skilled nursing facility. I now have the capability to do that in their home. So we've been able to show that that can occur. And I think what Raphael's talking about is right, that we were talking about being able to bring, patient-centered care into that venue where we can actually take care of that person. And then one last thing to sort of put a fine point on this, that we've learned over the course of this last year and a half, is that you get greater insight into that person. So it's not just the patient. You're learning about their home. You're learning about the fall risk. You're learning about what they're eating out of their refrigerator. You're doing real med reconciliation. So what I mean by real med reconciliation, and I've done this before actually in my HIV practice, where you go to the person's home and you say, "What are you taking?" And they're like, "Well, go on that kitchen table. This is what I'm taking." Well, that certainly doesn't line up with what I've got in the EHR. Now I can do real med rec. So all of those things become possible once you've got eyes into the home, either virtually or with your community paramedic.
And I would just echo much of what Raphael and Stephen have shared in terms of COVID-19 not creating the forces of change that are driving transformation within healthcare. I've been fortunate to be in healthcare leadership for about 2 decades now. And for the entirety of my career, and I suspect for significantly longer, we've been talking about how do we control cost? How do we improve access? How do we ensure that outcomes are the best that they can be and that they're equitably available to broad populations? Those have been the drumbeats in healthcare. And I would say all of our organizations have done good work to move the ball forward down the field. The challenge is when you intersect healthcare with the digital environment, that pace of change of real work that we're doing is this glacial pace that's moving so slowly. Yet if you look at other industries, they are completely transformed at a really rapid pace by integrating digital capabilities. And so what we see is COVID-19 unlocked the opportunity by pulling away some of the regulatory issues, the payment issues, patient acceptance, provider acceptance, and created this landscape within which all of a sudden we were able to quickly demonstrate the clinical efficacy of things we've been talking about for years, demonstrate that patients actually want this. The challenge now is that we sit on the precipice of the public health emergency going away. And now we have to, as an industry, grapple with the issue of, do we face a rollback? Is that our future where we essentially reset and we try to put the genie back in the bottle? I think very few people think that that's going to happen. The other opportunity is people see this wild west where anything goes and everyone rushes in. And I think what we need to do ultimately is try to find a way to thread the needle where we don't put unreasonable barriers to entry, and we do allow the freedoms that have been provided by these waivers to persist. But we also address what is, I think, a real fear by lots of parties that we will open up, because of the ease of access, overutilization that will increase the total cost of care, or that will bring bad actors who see a profit motive and try to get in and deliver less than high quality care and get out of their skis and start to deliver virtual care in ways that don't have the layers of redundancy and the thoughtfulness that Raphael and Stephen have built in their programs. And so to me, the sweet spot is trying to find a way that we build safe guardrails to protect the ability for innovation, for diffusion, for discovery, while still providing sufficient guardrails. And I think that that's what lies ahead and what we collectively will have to grapple with post-pandemic.
And that's great. And actually, I'd like to build on that, AJ. So I think we'll stay with you. You know, there are a number of, as you noted, temporary policies because of the public health emergency in place that are allowing the broader use of telehealth, hospital in the home, you know, really a number of new care delivery methods, right? That just either you had to get individual waivers for, or that you couldn't do before, right? And now are writ large allowed to sort of proceed with. And so, you know, and I like, you know, you brought up the guardrails around, you know, as we move this forward, making sure that quality care is what's delivered and not just any care, right? You want to make sure that it's high level. So we'll start with you, and then I'm interested in what the other two have to say here as well. But, you know, what needs to be done to allow these to stay in place and allow them to take hold more broadly? And I mean, beyond just the regulatory changes, right? You know, how do payment models need to be structured? Will it work within a fee for service model? Does it need to be prospective or value based? Just any thoughts you have on that overall?
Sure. Well, I'm excited to hear Raphael's thoughts because I know he's thought about this deeply, but I would say I think value-based care is here to stay. And as we look at opportunities for us to be able to drive a focus on patient-centered outcomes and value, and move away from some of the discrete work that we do where there's these episodes of care and care transitions where we can take a step back and look at managing outcomes for patient populations over time. Kaiser certainly has been a leader in this space for a very, very long time. And I think we all in the healthcare system owe them a debt of gratitude for leading and driving some of the things that we've all adopted. And so to me, I think the goal is to figure out ways that we can simultaneously innovate around technology. And I think we'll need guardrails, to use the same term, around protecting data, patient safety, security. We've all seen stories of organizations being hacked. And as we move more and more into the digital space, we need to ensure that we have environments that have the utmost safety of our digital environments. We'll need to also look and innovate around the care delivery models, the payment models, and the regulatory models. And if we advance too far down the field in any one of these spaces and unconnected to the others, I think we'll be unsuccessful. And so linking security, payment, innovation, and regulation collectively is, I think, what we need to do. And so we'll need to figure out ways that we as an industry can collectively come together and advocate and move things forward and speak with one voice, hopefully focused on the needs of the patient.
Great. And I think we'll go with Steve next, and then we'll end with Raphael, because I have a follow up on it as well.
Yeah, so I would agree here. You know, when I think about and I'll focus right now on the waivers that are related to hospital at home, the hospital without walls waivers. You know, and they were put in place, you know, in the context of an emergency, and we're coming out of the emergency. We've seen the innovation occur. We've shown, and I think we will be able to actually produce even more data now that we have, you know, thousands of patients that have gone through this program as opposed to hundreds, which was the previously published data. And I think this needs to come of age. So what I mean by that is that, you know, some of the guardrails that AJ's referring to in terms of holding ourselves to the same standards we do within the hospital system, you know, when it comes to the care experience measures, CAPS measures, measures around quality, that, you know, we should hold ourselves to those same levels and standards, whether it's provided in a home or in a traditional hospital building. And we need to actually make that happen. And I think that can be informed by experts within the hospital industry, within the clinical realm, physicians. I think that's how we need to inform policymakers going forward. Number two is definitions. So I think as one of the biggest issues with hospital at home is, who are we talking about? What patient population? And that gets to the reimbursement model that AJ is referring to, and I'm sure Raphael's going to touch on. And if CMS and others are going to be comfortable with this, we need to be clear on who's getting hospital level care, who's getting home level services, skilled services, that type of thing, because that is a totally appropriate question to be asking in this larger, bigger healthcare ecosystem debate that we're working through as a country. Because at the end of the day, you want this to actually be both effective from the standpoint of taking care of patients and doing a good job in terms of outcomes, as well as satisfaction. And on the other end, at the end of the day, having a more cost-effective model than the current existing system that we have in place today in the US.
So I guess, by the way, AJ, Steve, thank you for that. Bobby, the most intriguing question that invades my mind, unfortunately, all day long, every day, is related to the macro experience we're all having, not just as a country, but as a world, where we're sharing this experience of obviously living through a pandemic together, with or without our vaccination cards, with or without our masks, with or without a red state or a blue state. But the most interesting thing to me is the largest economic sector in the world is US hospitals. There's nothing larger in terms of economic activity. And if you look at the model through which it operates, which is the US healthcare system, and you start to hit the edges of it with the things that we've done, things that both Mayo and Kaiser did during the pandemic and continue to do, the real question is there a wholesale shift in the actual model of delivering care? Now, if I told you I wanted to open up a shopping mall now, you would tell me you're crazy. No one would open up a bricks and mortar shopping mall now, in the same way no one would start a taxi company. No one in their right mind would enter an old model, given the validation that the transformation of that model through technology and logistics has happened. In the same way, the real question is, are we fighting at the edges of the old model when we talk about regulatory constraints and or reimbursement? Reimbursement for a hospital stay for 4.5 days is what it is because of the DRG structure and all the other structures that are based on the assumption that patients have to be hospitalized in a bricks and mortar facility. But if we cared about the costs and the patient experience, we'd never even use the word post-acute care. It's an artifact of reimbursement. The patient's sick until they're not sick anymore. They're not post-acute sick and then pre-acute sick. They're sick or they're not sick. So if we were thinking about patient needs and economics, we would care for the patient until they were well, which means we'd have to have a reimbursement system that looked more like bundles, more like risk, more like value. On the other hand, we wouldn't even look at episodes. We'd look longitudinally the way Kaiser does and say, we have to own this patient longitudinally because their care changes, their needs change throughout the year. So there's no way we could constrain the payment just to an episode. So value-based payments, which is still part of the old framework, is trying to torture itself through the old framework in a new framework where the best care can be delivered in the best site for the best patient experience, best outcomes. We're going to rethink what regulatory structure needs to look like, as well as reimbursement. But we're in that middle period now. And in that middle period, it's going to take a lot of leadership, an extraordinary amount of patience, and a lot of education for the press, both the consumer press as well as the professional and clinical press, because value-based payments means different things to different people. What type of risk contract you're getting into? Upside, downside, two-sided? Are you literally going to create new sites of care? What happens when your CFO shows up and says, you've just tripped a wire, we're under 75% hospital utilization, we got to fill those beds again, or we're going to have to shut down? So all of these questions are artifacts of the old model that we're living in. We, Kaiser, Mayo, and others are trying to transform that model. And in the process of transformation, there's going to be a lot of thinking and a lot of conversation, but every question around regulatory and reimbursement is based on the vertical siloed way we deliver care that's facility-based. As we move forward with this and get more and more data, that'll change. And I hope it changes, in the next 10 years, because I've been at this for 13 years. but we're in the process of delivering that change. And to Steve's point, the pandemic forced us to recognize that certain requirements, both safety and capacity, forced us to be creative, and we were, and it worked. So now the real question is who the leadership is of the regulatory and payment structure, and how innovative and open they are to new thinking. That's kind of where we are, at least in my view.
And Steve, did you want to jump in here again?
Yeah, Bobby, I just wanted to add one other thing, and this is just to maybe be a little provocative, and I think my colleagues at the Mayo Clinic platform probably are thinking along the same lines here, which is that, we've got more and more access to, patient information, right? So we've got predictive models. A lot of those were initially inpatient based, where I could predict a person's going to deteriorate before they actually deteriorate. And, over the last 3 years, I would say my analytic team's been coming to me and saying, we don't just have to do that on the inpatient side, we can do that on the outpatient side. And actually where we've kind of fallen short is that actually we can unlock those predictive models and pretty much know, this person's at risk for developing X, Y, or Z condition. And if we intervened in some form or fashion, that would prevent an emergency department visit or prevent a hospitalization. But we haven't had the means to get into people's homes to provide exactly what they need. And so it goes to Raphael's point, which is that we need to be thinking broader, thinking along the entire spectrum of care, and being able to tailor what needs to get into that person's home and do it faster. And what I think this pandemic has shown is that it can be done to scale. And if we put our collective minds to it, put our collective resources to it, what we're really talking about is what Raphael's getting at. I mean, this is rethinking how we provide just general care, not just hospital care in people's homes.
Imagine, if you will, fill in the blank rural community in the United States that has a population of 20,000 people. It has a critical access hospital with 25 beds and average daily census of 5. And it's the largest employer in town. So all the political forces for the workforce staying intact are pretty strong, but it doesn't get utilized anywhere near its capacity. So which means is it loses a lot of money, and very precious, economic resources are placed on this unsustainable economic model. And to compound that, the patients in that community go elsewhere, either another community or out of state for care, because they don't trust the actual care that's delivered there. Now imagine that hospital costs, $5 million a year to operate, to be conservative. Now imagine you put super highly trained, consolidated paramedics in that same community, link it to a command center elsewhere that has the best minds for critical decision-making around care. Now, all of a sudden, you've replaced the infrastructure, which is no longer serving that community, liberated a lot of economic power to provide more care over a longer period of time in the patient's home. But you've got the political forces at work. And that's not value-based payment. That's community redesign of care delivery. And the economics are very compelling. And it's not one episode versus another. It's one entire community delivering care in a different model. That level of thinking hasn't really started yet. We're starting that, obviously, as I mentioned, in Oklahoma. But that next level of thinking, which is wholesale translation of decentralized care at a community level, that's where the real economics are going to come from. But in the meantime, we're going to torture ourselves with value-based payments, bundled payments, regulatory constraints, et cetera.
AJ, did you want to jump in?
Oh, no, just going to agree in sharing that what we've done is looked at a system that delivers pretty good care today, but the opportunity is to provide truly exceptional and excellent care across a number of different domains. And so we've started to do, again, really aggressive remote patient monitoring. We've got hospital at home. We have a care hotel that substitutes for hospital-based care. We're looking at a number of different places across the continuum. And what we started to do is take a step back and say, what we really need is an end-to-end solution that is seamless for the patient, that provides the best care in the appropriate setting with the right care teams. And so now we're shifting away from a focus on hospital at home, but really a care portfolio that can be virtual and is highly scalable and only brings as much cost to bear as the care that that patient needs. The challenging part is that for many places across that virtual care continuum, there isn't an economic model that exists to provide that kind of service. And so what we've looked to do is partner with payers to say, let us carve out a population point of care, some kind of a place that we can just create a sandbox where we can innovate together. And we're not going to try to argue, though we typically do the process of, we dance and fight over the dollars, but let's, for this space, carve something out and just commit to innovate together. And so that's been really powerful, that we've now starting to see not only supplier partners, but payer partners and others say, all right, let's leave some of the ego and some of the other pieces at the door, and let's just try to find some things that where we can innovate, and let's make it small enough so that if for some reason we screw it up, it will be okay, because the economics aren't going to be such that it will be disastrous for anyone, but instead we can really innovate around, again, what's best for the patient.
That's great. And so before we move on, I just want to thank those who have submitted questions through the Q&A. We're going to get to most of those. And if you have additional questions, please continue to enter them, and we'll get them answered as we can. So, and so I'm going to pivot, and you all have mentioned a couple of the challenges ongoing here, and one of our questioners raised another one. And Steve, I don't think we started with you on a question yet, so maybe we'll start here with you. One concern around telehealth in particular is access to it, right? Is the equity of access to the care, and how that plays into the continuing challenges with health equity. And similarly in rural areas, and Raphael touched on this a little bit, is again just the access to the care. And so maybe talk to us a little bit about either those challenges or any others that you see facing this a new model of care delivery, and then how some ways that it can be addressed.
Yeah, so I mean, I think a couple of things. So one is that there's the obvious, which is the technology able to reach people? So broadband, do people have access to that? And the good news is that the federal government is now actually, hopefully with the infrastructure bill that is winding its way through Congress, going to begin to address that. Raphael will probably comment on this himself, but I think there are there's actually a need for the healthcare industry to actually engage other stakeholders. So we sort of wave our hand and say that broadband's not available, and yet maybe it is available, and yet literally the pipes haven't been hooked up. And so are we engaging with the right local and state regulatory agencies and or oversight to actually hook up the pipes, literally? I'm talking about like fiber optics and that type of thing, stuff that I didn't have to think about in medical school, but it's critically important. The second thing, and this was something that Kaiser Permanente studied actually during the pandemic, which was this critical question about access to care. And what we found was that if you're in a Black, Brown, or Asian community, or in a neighborhood that has a higher deprivation index compared to others, you're more likely to get infected with COVID. You're more likely to have to come into the emergency department. If you come into one of the Kaiser Permanente emergency departments, at least in Northern California, once you get hospitalized, your risk of death, your risk of disability is equalized. So it's my firm belief that if we can, and we have to, move whatever's going on in that hospital, it's equalizing those disparities. It now has to be brought into those homes. What do I think that means? It means figuring out the technology, the redundancies that need to be in place to make that happen. And by the way, this is not just a rural issue. There are urban deserts, if you will, that we need to address. The second thing is who needs to be in that home. So some of the traditional models that we've had, where it's home health nursing, or the actual doctor going out to the home, those aren't scalable. I'm just being quite frank here. And so, having alternative practitioners going into those homes, breaking some of the rules or remaking some of the rules, if you will, around community paramedicine, I think is going to be critically important for this country. And we literally have states in this country that ban the use of community paramedicine. We've got to rethink that. Allowing physician assistants and others to serve as extenders. And by the way, the other thing, and I'll get on my soapbox about chronic complex care too, is that it's not all licensed practitioners that are going to also contribute, I think, in the end. And so having, the right, navigators that are connected to the care teams. And we've got to think through what are the HIPAA implications in terms of access to the medical record and appropriate levels of access. Those are going to be all the things that I think you have to address to get at this disparity question. But I firmly believe we can do it because I saw it happen during the pandemic. And so that's actually part of the work going forward.
Yeah, and I'll go to Raphael last. I want to go to AJ next, and Steve alluded to this a little bit, but AJ, interested in your thoughts on the question writ large, but then also then, there are going to be cultural issues, and not just within, minority communities, but also in rural communities around using this technology instead of going to what they're used to, or even just acceptance of that style of care. So, any thoughts you have on how those can be addressed as part of this model?
Sure. So maybe I'll comment on two things, the cultural pieces, and then also just build on some comments Stephen made about just the workforce of the future. From a cultural standpoint, one of the things we've realized is we have significant amounts of work to do in that regard. Our first effort was, can we deliver the model safely and efficiently? And we've been able to really demonstrate that that's the case. We've got lots of data proving that out. And now the question is, how do we continue to calibrate the model so that we're not just delivering technically safe care and effective care and cost-effective care, but how do we deliver culturally competent care as well? So examples would be right now in our electronic interface, I think we have English and Spanish in our home-based tablets. So there's a whole community of people that we're not serving in terms of accessibility. We offer medical meals as a part of this process, but we haven't necessarily gotten to the point where we have culturally expansive and inclusive meal options. And so as we walk all the way through this process to be able to look at people who are in underserved communities and how do we make sure that we're delivering true accessible and inclusive care, there's a fair amount of work to be done. One of the things we've identified on our part is the need for service designers. And so much as if we look at technology providers, they spend a significant amount of time looking at how the user interacts with technology. We're also planning to bring on board people whose entire career and expertise, certainly it's not mine, is to look at how the family lives with the technology. What is their journey over the course of a day? And make sure that we're able to include in the process, again, not just clinical efficacy, but also cultural competence as well. And so that's one of the things, that's one of our key outcome and key objectives, or OKRs for this year, is the integration of diversity, equity, and inclusion initiatives. To answer or comment on the other question that surfaced, which I think is an amazing one, is the things and challenges that we'll need to overcome. I think the second that I see is just staffing and that workforce issue. As we think about in healthcare, physicians, the board certified field of intensivists, critical care practitioners, didn't exist for much of medicine. It wasn't until the 70s that we had intensivists, people who specialized in delivering intensive care. We look at hospitalists, that field didn't really exist and become board certifiable until the 90s, as we looked at people who specialized in hospital-based care. I think the same is true for virtualists, people who deliver virtual care and understand how to empathize, how to sort of electronically hold the patient's hand in terms of being there, engaged, connected. The entire field of navigating technology to deliver care, I think, is one that's critically important. Community paramedics is another. I think there's likely, if we map out the career fields that will be necessary to make this wildly successful in the future, there's several career fields that we will need that don't exist today. And so we think about upskilling the existing workforce, creating new training programs, changing regulatory guidelines to enable folks like community paramedics so that we're able to have the workforce of the future. I think that will be hugely important, because today we're operating a brand new care delivery model using the workforce of 10 or 20 years ago. And we'll need to spend some time really addressing that as a key issue.
Yeah, and Raphael, I want to hear from you here as well. And then we've gotten a few questions about, within the rural space. And so just interested in maybe your summation answer to some of those questions that have come in.
Bobby, just, I would typing answers. I don't know if they went up, if they went broadly to everyone, but I have this overwhelming desire all the time to take all the air and the water and dehydrate thinking and complexity into simple acronyms. And the one that's my favorite right now is ILL, ill, because it works well thinking about healthcare. And the quality of partners that we have in Mayo and Kaiser, obviously, I'm blessed beyond measure to have those types of partners. But the three letters, let's start with the I. So people in healthcare that work in healthcare, whether they're in the administrative or the clinical side, they tend to have an enormous amount of intellect. This is one of the smartest industries, highly trained, highly educated, sophisticated thinkers. So even though they have the ability to have insight into what might change, they're trapped in this old model and the incentives, which are really not aligned to actually transform the care model, they're really to protect the old model. So to really change care to the area of questions that have come up, there has to be anchoring around a few insights. And I have my own, one of which is you can't bifurcate or silo care with acute, post-acute, which I've already covered, and you can't use critical access hospitals and bricks and mortar to solve for dispersed populations. Those are just two tiny pieces of insight. So the first is you have to anchor on insight that's immutable truths that you have to solve for and not argue about them and not debate them. 2, L, often forgotten, almost never comes up in conversations about healthcare anymore. You have to love your patients. You have to love them, not like them, not care for them, not have great processes and protocols. You actually have to love them, because when someone's ill or vulnerable, they really need their caregiver to truly care for them. And it's such an underused word, and it began as an overused word when we cared for patients. And Mayo's history with nuns, partnering with surgeons to actually create the Mayo Clinic is one of my favorite stories in the world, and it inspires me. So we stopped talking about loving patients. So that's the number 2. And number 3 is leadership. Things that need to be transformed based on insight and love really need someone to step forward and say, this is really hard. I don't know how I'm actually going to do it, but I'm going to declare I'm going to do it ahead of doing it. And then I'm going to force innovation and creativity to kind of come to the answers, and I'll have everyone follow me. We have a fair number of leaders in this country, particularly the ones that are on this telecast right now with Kaiser and Mayo. We need more. And I've had the good fortune to meet a lot of really strong healthcare executives who are waiting to see what Kaiser and Mayo does before they do anything. And I wouldn't put them in the bucket of leaders. I put them in the bucket of followers. So I think we need more leaders. Now we have who we have. We have the good fortune of having real leaders driving this. We have the insight. We know what needs to get done. We have the evidence that the insight is right. And we need to care more about our patients, a lot more about our patients, and translate that message. But to me, every issue, whether it's, urban care deserts, underserved patients, we know exactly what we need to do. We know how to do it. It's just hard from a regulatory standpoint. It's hard from a workforce standpoint. And it's really hard from a payment standpoint, because we're still living with the artifacts of the old model. But, ILL, insight, love, and leadership, to me, that's where we need to all go as a nation of healthcare leaders.
Great. And, I think we could probably have this conversation for an extended period of time. Unfortunately, we're sort of coming up against the clock here a little bit. So I'm interested in getting closing thoughts from all of you, just, things that you think you want to add to the conversation. But, and I'll just throw one question out there maybe for your comment that have come up along the way. And that's how this impacts physicians and how it impacts payers, and just sort of like how you weave their I'll call it buy-in into this changed mode of care, as well as things are moving along to get to the destination that's going to be best for patients. And so we'll start with Raphael, and then go Steve and AJ, and then we'll wrap up. So Raphael.
Yeah, providers went through a lot to become providers, and payers have a motivation that's really clearly economically rooted. My view is, and it's not naive, believe me, my view is do what's best for the patients, prove it with data, and the payers will come along, because economically their alignment is self-evident. But we still have the burden as providers And that's why we've aligned with providers, not payers. We have the burden to provide that data to those payers to prove that while we're delivering better care, better outcomes, we're also delivering a superior economic value proposition. So my view is don't worry about payers, worry about patients and making providers happy and rewarding providers with great feedback from great patient care, because that's why they became caregivers to begin with, is the feedback of saving lives and healing human beings. So I'm less worried about payers. I'm more worried that we bring the right kind of providers into the mix with the right motivation.
Great. Steve?
Before we actually launched the journey, we actually took a step back and said we need to survey our patients and we need to survey physicians, nurses, and understand where they're coming from. So we actually threw out a number of sort of, again, provocative questions about, would you be comfortable doing this? What would make you comfortable? What are the positives? What are the negatives? So actually talking to the provider physician community and understanding where they're coming from, and then addressing those needs, and then going through the iterative process as we have done with the launch of our programs, and then continually improving. So taking that performance improvement mindset and applying it, really key. And incorporating in those new insights at the literally down to the patient level, which Raphael's talking about. When I think about the employers, I think broadly here. So I do think it's important to engage the employers and to explain what we're about, because they are, still paying and footing the bill for 60% of people who get healthcare in this country. And they do have, in addition to the economic interests that Raphael's talking about, I think they have an interest in, the health of their workforce, so that they can be at work as opposed to somewhere else. And understanding that from a cost perspective, and also just from a centering perspective of being able to not have to be off work as long if they're able to recover in their home, I think is a pretty compelling argument. And there are coalitions of employers out there for us to engage. And I think that leads to sort of the third sort of leg here, which is that, Medicare, Medicaid, which means the state and federal governments have an interest here. And we have a broad interest, right? Because we're talking about the expansion of care to communities that have not had adequate access. And that is a charge that resonates, at least for us at Kaiser Permanente, I think as physicians, in terms of why we went into this field. And it is a charge that these government programs have as well. And so I think employers, along with physicians and provider groups coming together to be able to explain what this model is, why it's needed, and why Medicare and Medicaid should be thinking about this, not just in the short term for the public health emergency, but for the long term, as we were discussing during this webinar, I think is critically important.
AJ.
Thanks. So I'm just reflecting on Raphael's comments about the fact that this is really hard work and we need leaders to step in and move us forward, because ultimately patients need it, the economy needs it. It's just the right thing to do. So, I think about the work that lies ahead for us, and it feels like we do have to be bold. We have to be disciplined in building really effective business cases. We have to be thoughtful. We have to be strategic. There's this litany of things that we need to do to really make sure that we are up for the task ahead of us. But I just wanted to also maybe share a different perspective, which is I formally and officially have the best job at Mayo Clinic. It's sort of written into the sort of our online directory of folks, and I've got as my title, best job at Mayo Clinic, because as we look at the work that we've been able to do as a broad team, our patients every day are telling us how transformative it is for their lives. Patients have historically had to put everything on hold and turn themselves over to hospitals, pretty good hospitals, but still turn themselves over. And we've had story after story of people who have been just moved by the ability to be home with their loved ones while their loved ones were going through difficult things as they went through receiving their health care. I've had physicians who work in our program tell me that they've been able to practice the best medicine of their careers as hospitalists who previously would send the patients off to Raphael's least favorite term, the post-acute setting, and hope that they were able to get the care that they needed to progress with their journey to health. And instead, they're able to walk with them from the most acute to the restorative phases of their care and walk with them through that journey, and how rewarding it is and how much relief they feel from being able to see that patient get well. We've had staff members talk to us about the ability to drive clinical innovation and taking new patients into the model. So I think there is two ways to look at the work ahead of us. One is we've got to put our shoulder to the grindstone and do really tough work and be disciplined about it. The other is this is an amazing opportunity that's incredibly fulfilling, and I'm just thrilled we'll be able to take the journey as a group together.
That's excellent. And thanks again to all of you. This was a really interesting conversation. It was great to get your perspectives and insight. And we're excited to see this partnership develop and expand beyond it. So
Thank you, everyone.
Thank you. And thanks to all of you for attending today. We appreciate it. And please join us next time for our next webinar here at the Medical Alley Association.